Hi, I'm Jill Foose, and welcome to Afterpause. This podcast is for the woman who has made it through menopause and is ready to own what comes next. The woman who refuses to disappear, who still wants optimal health, energy, strength, power, great sex, confidence, style, beautiful hair and skin, and the next 20 to 30 years of her life to actually feel like living and knows she deserves every bit of it. This is Afterpause, and it's just getting good. Every episode is a real conversation built around one goal, telling you exactly what to do next. No guesswork, no noise, just clarity, direction, and action. Let's get into it. Hi, everyone, and welcome back. Before we get into today's episode, I want to take a moment to tell you something very exciting. The Health Trip podcast is getting a new name. Starting now, this podcast is called Afterpause with Jill Foose, and here's why. After years of doing this work and coaching women through menopause, sitting across from some of the best physicians in this space and navigating the stage myself, I kept coming back to the same observation. Women are getting information and lots of it. What they are not getting is direction. They leave appointments, they finish articles, they listen to podcasts, and they still don't know what to do next. And that gap between knowing and doing is exactly where I work. Afterpause is the name I'm giving to this stage of life, not menopause, which is a single moment in time, not postmenopause, which sounds like something is over. Afterpause, because what comes after is not an ending. It's the longest, most important chapter most of us will ever live. 20 to 30 years of that deserves a roadmap. That's what this podcast is now built to give you: real conversations, real physicians, and real direction. So you leave every episode knowing exactly what to do next. The new name is my commitment to you, and that is the same, giving you direction and information all in one. Now, let's get to today's episode. Heart disease is still the number one killer of women, not breast cancer, not ovarian cancer. It's heart disease. And yet, most women and many of their doctors still don't recognize it in time. And why? Because heart disease in women doesn't look the way we've been taught. No crushing chest pain, no dramatic collapse. Instead, fatigue, jaw pain, nausea, GI upset, symptoms so commonly dismissed as anxiety or perimenopause that when women leave emergency rooms undiagnosed, undertreated, and in danger, issues occur further down the line. I've been a hockey mom for the last 29 years, and sadly, every year I hear about a hockey mom who's died from a heart attack. And these are women who are in their 50s, some healthy, maybe some not so healthy. The message is always the same from their family members and friends. It was out of nowhere, or it was sudden. It was unexpected. And what I have learned over the years of interviewing some of the best preventive cardiologists is that heart attacks don't just show up. They've been brewing for years, decades. No one has looked. My guest today is another one of the best. She has made it her life's mission to change the trajectory of women's heart health. Dr. Jayne Morgan is one of the country's leading cardiologists and a fierce advocate for women's cardiovascular health. She is the Vice President of Medical Affairs at Hello Heart and one of the most compelling voices in the menopause space on the intersection of estrogen, hormones, and the heart. I have wanted to have this conversation for a long time, and I think once you hear it, you're going to feel the exact same way. Hi, Dr. Morgan. Welcome to Afterpause with Jill Foose.
How are you, Jill? I am pleased to be your first guest in your Afterpause.
You are, and it's such an important topic of talking about postmenopausal women and their heart health. And so to me, I don't like the word postmenopause. It means like there's a door closing, but afterpause is after what's happening, after the pause is over. We are still in this phase of life, but it looks different. And instead of it being gloom and doom, I want it to be this really positive experience for women.
Right, right. And it really is. There are just so many positives. And I think, where I sit in cardiology, I am simply interested in making certain that women take care of their hearts as well during this period of time.
Exactly. And that's why I wanted to have you on the podcast, because so many women that I talk to who are in their 60s or 70s and even their 80s, when I talk about menopause to them, they give me a look like, ah, that was in another lifetime. I don't even think about that anymore. And I always say, no, you have got to keep thinking about it. This is something that is not going to go away. It is with us until we are 6 feet under, and we need to be conscientious about our health journey.
Right. Yeah. No, you're absolutely correct. And part of the challenge when we think about perimenopause or menopause or after pause is we always are thinking about gynecology because it's centered around sort of the menstrual cycle. And so that's where the focus is, when in fact, part of what I try to impart on people is that that's really just the signal. That's the
Yeah.
signal to the heart. And so it's sort of like, look over here while we're supposed to be looking over there. It's kind of a distraction. But because it happens as a part of the reproductive system, we are sort of thinking, oh, this is all about reproduction. When in fact, no, it is just a biomarker of changes in the rest of your body where estrogen impacts many other organs, including the heart.
And especially for women who kind of breeze through the menopause transition and don't really have a lot of symptoms or any. And I have met women like that. I,
I have not, but
oh,
okay.
I
I think
have.
maybe I know one. I've met one.
Yeah. And I still say it's just like a car. You still have to look under the hood and see
Right.
what's going on with the engine. So, heart disease awareness in women has been a campaign for years. Are we
Mhm.
actually making progress?
I'd like to say that we are. I think that I'm seeing progress in the American Heart Association, the American College of Cardiology. At least there's some discussion about it. There's inclusion of the words in the guideline, even though it's still not as encompassing as I'd like to see. There is broader discussion as well, certainly amongst female physicians, even if they don't have the knowledge or the training, they now have heard about it and are wondering what's happening, and their patients are coming and asking them about it. So I think, the tentacles are starting to socialize. Where we need to really make big inroads is in medical education. I mean, the
Yeah.
foundation of medicine with regard to the care of women has simply just been a failure. And it starts with the medical foundation, medical school, medical training, residencies, fellowships, where we are still shaping and molding and teaching and training our future doctors. That's where we've got to integrate it so that they come out and it's already a part of their training and what they are prepared and expecting to do with their patient population. We still have a gap there.
So, how did you personally come to focus on women's cardiovascular health?
Long story, but I will just say, in my cardiology fellowship, I noticed often that I would be admitting patients with this diagnosis called atypical chest pain or atypical symptoms. And I began to notice that most of the people that I admitted with those symptoms were always women. I almost never admitted a man with a diagnosis of atypical chest pain. The men had sort of the classic chest pain. It wasn't called classic, right? It's just called chest pain. But
Mhm.
women are atypical. And that word atypical began to bother me. Like, why is this atypical? And the women necessarily wouldn't come in with chest pain or shortness of breath, or, dizziness or sweatiness. Sometimes they just felt run down. They weren't feeling well. They had nausea. They just couldn't shake it. And maybe they would have twinges of pain in the left arm, maybe the right arm, maybe the back pain. And so for the medical system, this was vague. Nobody quite knew what that was. Maybe it's heart, maybe it's not, maybe. And oftentimes the full diagnosis was atypical chest pain, rule out panic disorder. There's an official CPT code uh, for reimbursement from
Mhm, mhm.
insurance companies. And we almost never admitted men with chest pain rule out panic disorder. And what that word did as I looked back over my fellowship training is it triaged women to lower levels of care and concern. That one word, atypical, means you're sitting and waiting while we are maybe figuring it out or drawing some labs or looking at patients. When I say patients, I mean men who are more important because they've got the classic pain and we all know how to respond to it and we are doing intervention and rushing them off to the cath lab. This lady, it's probably a panic disorder, but let's just draw some labs. Let's see. We let her sit when in fact they both are equally having heart attacks. And that's why the first heart attack of a woman is more often fatal than the first heart attack of a man. That's why women are twice as likely to die. It's not just the neglect, it is the delay in recognition and the delay in care
Mhm.
and urgency.
Yeah. I'm a hockey mom for now almost 30 years. And
Mhm.
I can't tell you how many women I know each year that have suddenly died of a heart attack in the hockey community.
Wow.
These moms who are in their 50s. So at least one a year that I hear about. And it's always with the words sudden or
Right.
out of nowhere.
Right.
And I always say,
Unexpected.
unexpected, right. And I wonder, if obviously they weren't having their heart health assessed in their 40s and 50s. I talk about that all the time. I've had other preventive cardiologists on my podcast to talk about being more of an advocate for yourself and getting the testing done, which we're going to talk about. But heart disease is the number one killer of women and men. And, it makes perfect sense what you're saying, that we are underdiagnosed and not taken this seriously. And it's a huge problem.
It is a huge problem. It's a huge challenge, and um, generally we see changes in patient care coming from the medical community and going out. But, in this case, it's me, and I'm a part of the medical community, and other doctors who are parts of the medical community, and other healthcare workers who are parts of the medical community, but are having to work outside of the system to sort of get the system inside to respond. So it's almost as if we have
Yeah.
to work outside the system, get the information to people, and start knocking on the doors of the health system. So, many people, I mean, like you and I are sort of straddling. We are one foot in the health system where we work, another foot outside the health system where we're also addressing public health and making certain people are informed.
Yeah. When does a woman's cardiovascular risk actually start changing? And why do most cardiologists just not even talk about perimenopause?
So a woman has several times in life when her um, cardiovascular risk would change. One would be during pregnancy,
Hmm.
pregnancy complications, and pregnancy complications such as hypertension during pregnancy, which is high blood pressure, or diabetes during pregnancy. Sometimes we call that gestational diabetes, or terms like preeclampsia, which is high blood pressure that also now is impacting other organs in your body, more commonly the kidney, or even eclampsia. Older term is toxemia, where you may even start to have seizures from your elevated blood pressure. And then even things like low birth weight babies. So I want to talk about that because if you have any of those complications during your pregnancy, your risk of heart disease is twice that, more than twice that of the general population of women. And that is because the pregnancy in a woman is the first stress test of her heart. It's
Mm,
a physiologic stress test. And if you've developed any of those complications, you have failed your stress test. And like anyone else who fails a stress test, they have an immediate referral to a cardiologist for further workup, assessment, evaluation, and recommendations. But for women, we don't see it that way. And that's because all of the doctors work in silos. So a woman's care, by and large, is managed by the OBGYN. So they're not looking through a cardiology lens. They are what? Taking care of baby, taking care of mom, trying to get you through the pregnancy. And so what they see, an example, OBGYN has a patient, 36-year-old female in her 32nd week of pregnancy with preeclampsia. The thought was the treatment for preeclampsia was just to get the mother to the point of delivery. And after the baby is delivered safely, all of those indices return to normal and everything is fine. But we now know that that is not. Again, this is a biomarker. And so a cardiologist looking at that same patient where the OBGYN says this is a 36-year-old female, 32nd week of pregnancy with preeclampsia. A cardiologist walks in and says, this is a 36-year-old female in a volume overload state who has just failed her stress test. See, two different people looking at exactly the same patient from different lenses and having different trajectories of what they see as risk. And that's why, it's important when we talk about diversity. We have diversity of thought, diversity of perspective, diversity of training, bringing everybody in so you can have a whole picture of what's happening. Doctors work in silos, right? The cardiologists
Yeah.
never talk to the OBGYNs. OBGYNs are way on the other side of the hospital. They usually have their own wing. They have
Right.
their own entrance to the hospital. Like we don't even go over there. We don't even know what's over there. We
Mhm.
call it the happy land, right? The rest of us are kind of grinding it out with chronic
Right.
patients and ICUs and running codes. But the fact of the matter is, cardiologists should have been over there. There should be cardio OB units. And so that
Mm.
phase in a woman's life is a risk and it can identify risk. So I want to be clear to your listeners because oftentimes I say that and people say, women will say, you know what? I'm never going to have that because I'm just not going to get pregnant. And that'll fix that. That doesn't fix that. The pregnancy, I want to be clear about this too. The pregnancy didn't cause your elevated risk of heart disease. The pregnancy declared it. The pregnancy
Mm.
made it obvious. The
Mhm.
pregnancy told you about it. If it weren't for the pregnancy, you would not have even known about it.
Mm.
So
Wow,
again,
that
the
is a
pregnancy
really
doesn't cause it.
yeah.
It
What
is
an
letting you know. So without the pregnancy, you would not have known that you are at risk of heart disease. So I always want to make that distinction because I hear women say, I just won't get pregnant, I'll avoid it. No, that's not the
right.
answer.
Yeah, because as you were talking, I was thinking, all right, so the women who don't have any pregnancies,
Mhm.
who choose not to have a family,
Right.
are they better off? But you're already
No,
answering that question.
no, no, the risk is the same.
Right,
Pregnancy
right.
just declared it and made it obvious for you. And
Yeah.
because the reason for that is the pregnancy puts more of a demand on your vasculature. And if you're developing any of these complications, hypertension, diabetes, including low birth weight baby, if you're developing any of these complications, it's a uh, information to the system that your vasculature is compromised. Low birth weight babies are generally because there was not enough blood and perfusion to the baby. So if you've ever had a baby who was small, that is an indicator. Most people don't think that. Sometimes women are glad to have small babies. Woo, that was great.
Mhm.
Um, because it was less stress on the body. But the fact of the matter is that underweight baby is telling you you've got a problem, mom. And that's the connection we've never had because cardiologists are not on the team with the OBGYNs and we're not connecting the dots. And so there's not this whole care because since the beginning of time, since the beginning of healthcare, women's health has always been just reduced to just reproduction, right? We're just um, reproductive vessels and sexual vessels. We're just breasts and vaginas. And other than that, we are of no use. Clearly, we have no other organs. And so the health system, and by health system, I mean men, the health system didn't think about it, and women just kind of went along with it. And then medicine developed in all these specialty silos where we work in our little areas and we don't cross over. So you don't have different lenses. You don't have that diversity of looking across the spectrum, especially in women, and giving whole care, bringing people in who see things differently, who have different experiences, who have different training, who have a different lens. The same as me in my cardiology fellowship. I was the woman in our cardiology fellowship I have a different lens. All of these men there, but I'm noticing, why am I admitting women with atypical? That's not something that had ever occurred to them in decades of training. But now
Mm-hmm.
they have a woman, and and I'm asking that question. The men had accepted it. Women have panic attacks. This is it. I won't say I didn't accept it because they told me this was normal, but it bothered me. I was
Yeah.
noticing it. Something's not right. I know you're telling me that this is normal and it's been normalized, but it's bothering me. And it bothered me for the next 2 decades. Why is this happening? So, bringing someone in like me to the cardiology fellowship who is different from the traditional male, I had a different lens on the women.
Yeah. Well, thank goodness for you. You know, Dr. Morgan, I'm thinking about the women who are listening to this podcast right now, who are listening to you talk about pregnancies and all these biomarkers.
Right,
And they must be thinking to themselves, as I am, I had 5 babies. I'm thinking,
right,
okay, what were my pregnancies like? What were the
right.
weights of the babies? And this
Hmm.
is why this episode is so important for women who are
Right,
in their 50s and 60s and 70s who
right,
maybe haven't had a proper CVD workup to
right.
assess their risk. So, you know, thank you for bringing that forward. I want to move a little bit down the road to
Mhm. Mhm.
perimenopause because I'm
Right.
thinking that's the next phase of
That
life
is the
where,
next phase. Yeah, and I
yeah,
was going to say, Jill, just to kind of bring it full circle for women, the point that I made with, what I just talked about with
yeah,
pregnancy complications is that your pregnancy history is relevant for the rest of
hmm,
your life. You
yeah,
must give that history to your physician, whether they ask for it or not. Many still are not asking for it because a lot of the information I'm giving you today, the health system still is catching up to try to
hmm,
figure it out. But your history, your pregnancy history is important to your cardiac health and has to be a part of any evaluation for the rest of your life, especially if you've had pregnancy complications. You must always, always, always include that in your history. Many times we don't talk about our pregnancy, like, oh, they were fine. I did, the kid's grown, they're in college, blah, blah, blah. No,
right,
the pregnancy history is important. Okay, so now
yeah,
perimenopause. Then we get to the next phase of our lives. And, the fun thing about perimenopause is that it crosses over fertility and reaching menopause. So you are still fertile, you're still ovulating during
hmm,
perimenopause. It may not be as regularly, or it may be starting to be more irregular, but you're still fertile. So I want to be clear that perimenopause doesn't mean that you no longer need birth control. You know, say, oh, I'm in perimenopause. I didn't need birth control. No, perimenopause is different from menopause. Perimenopause are the years, sometimes 10 years leading up to menopause, where your estrogen levels have begun to decline, but they don't just drop at a precipitous, measurable, calculatable rate. They're like all over the place. They're fluctuating. Some days they're high, some days they're low. Some days they stay low for, sometimes they stay low for 3 days and then bounce back up. You're all over the place. That's why you get these perimenopausal symptoms. The ones that we talk about more frequently are the vasomotor symptoms. So the night sweats, the hot flashes. That's the rise and fall of that estrogen and progesterone outside of that 28-day cycle where we're used to having it. So that period of time also marks an increased risk of heart disease for women because estrogen protects the heart. We get confused about estrogen and say, oh, it comes from the ovaries. It's all about gynecology because that's what women's health is always about. But no, the ovaries are producing it, and also there are other organs that produce it, but primarily the
yeah,
ovaries are producing it. But it's going out to for the entire health of the woman. It is feeding the heart, right? We have estrogen receptors on our heart. It is making that heart stronger. It is a woman's natural anti-inflammatory agent, and inflammation is what drives atherosclerosis. So plaques in the arteries, inflammation, chronic inflammation also is a driver of cancer. So estrogen is our natural anti-inflammatory agent that we are now losing. So we are here in perimenopause, and our risk of heart disease is quietly increasing. Why? Blood pressure is going up because we're losing estrogen binding to receptors to arteries. So those arteries are stiffening. Cholesterol is starting to rise. Same reason. Cholesterol, yeah, estrogen levels are dropping. You've got sleeplessness. Why is that? Interruption of sleep, interruption of circadian rhythms. Blood pressure is up. Sleep deprivation or lack thereof is a direct risk factor for heart disease. Metabolism changes. Fat shifts from the hips into the belly, which is visceral fat. This is a metabolic change. That visceral fat is active. It acts as its own hormone, its own organ. And oftentimes, um, that is part of the whole metabolic change that is happening. You can have decreased insulin sensitivity, so an increase in insulin resistance, which is prediabetes. Everything that I'm naming are all independent risk factors for heart disease, and that have nothing to do with men or women. These are just risk factors for heart
Right.
disease. Imagine in a woman during perimenopause, these are all beginning to happen at the same time. And we kind of just shrug our shoulders. And when you think about that, in addition to the woman who had the pregnancy complications, who now
Mm.
is coming into perimenopause with a twofold higher risk of heart disease, now is in perimenopause and losing estrogen protection and having high blood pressure and cholesterol and all of these things. I like to say it's like Eminem's song. It's like when a tornado meets a volcano. And we do nothing, right? We turn on a fan, ha 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 ha, look at her sweating. This is so funny. When in fact, this woman's body is literally screaming to the world, look at me. My risk of heart disease is increasing and nobody's doing anything for me. Your body is literally shouting with these hot flashes. You're sweating, you're out of, everybody notices and no one does anything. The health system just turns away. Yeah, look at that. Another atypical woman with another panic or hot flash, that sort of thing. And we've got to stop normalizing the minimization and the marginalization of women's symptoms and also the way that we feel. I think our feelings are important. Our feelings actually distinguish us from men. And I think especially when we go into corporate America, we try to not say we feel, we want to say we think all the time. I think we need to own that sometimes we do feel it. And that's actually what makes us better leaders and better
Yeah.
members of the corporate world. And we don't have to sort of be like men.
Dr. Morgan, I meet so many women who tell me that they have hot flashes or night sweats, and their doctor just sort of dismisses them and tells them, it's just going to be a few years and on the other side, you'll be better. And I say, no, this is a risk factor. This is a warning sign. We have to get you with someone who understands cardiology, whether it's a lipidologist, a preventive cardiologist, your internist, whoever has advanced knowledge on lipids, that's who we're going to go to so you can assess your risk for heart disease. That's how important it is for women to understand that you're right. People do laugh it off. Oh, I'm sweating and I have to bring 2 extra shirts to work. And no,
Right.
that's not normal. And that's what it's been normalized, but it's not normal.
Absolutely right. It is not normal. And just, I cringed even when you said, oh, a male physician said, don't worry, it'll be a few years.
No,
What?
and female physicians.
Yeah, and female
Yeah.
physicians, as if
Mhm.
a few years of a decreased quality of your life. I'm taking cardiology out of it. You are uncomfortable and suffering, and then you are told, "Don't worry, it's just will be a few years." That's
Mhm.
an insane comment to make, and we have to remove the acceptance that a woman's suffering is something that should just be normalized. Women should just suffer. You should suffer through it. You should just grin and bear it. You should, just keep smiling. Um,
Mhm.
and we don't acknowledge that the suffering is real. It's of no importance. That this is what women are expected to do. Men are not expected to suffer, by the way.
No,
We would
no.
never say, listen, that'll just go on for a few years and then you'll be done with it.
Well,
Absolutely not.
Well, for men, it's erectile dysfunction, right? That's their
Right.
biggest biomarker of something going amiss with their heart health.
Right.
And
That's right.
they don't sit around and wait for it to go away in the next, 3 to 5 years. They go see their urologist and get
And
it
not
taken
only
care of.
that, and they get Viagra to
Right.
have a vigorous sex life. They never get their heart
Hmm.
checked, even though erectile dysfunction is the function of is a marker of heart
Hmm.
disease. And so, interestingly, the Viagra is actually putting more stress on the heart and pushing them
Hmm.
closer towards a heart attack. So, your therapy for your erectile dysfunction, you're not actually treating the root cause of it, which is heart disease. In fact, you're doing something that's going to put more stress on a heart that's probably already under stress. So there's that. So we won't talk
Yeah.
about men today and there,
Yeah,
but
yeah,
yeah,
yeah. So
exactly.
if a woman is in her late 40s or 50s and she walks into her doctor's office and she says, I want a full cardiovascular workup. I just listened to this podcast. I'm really interested in assessing my risk for heart disease. What should she be asking for that she may not have been getting before?
Yeah, so it varies. So it's going to vary according to a person's personal history. Again, we talked about pregnancy. We talked about, we didn't talk about the early menopause. We didn't talk about family history. So it's going to be your personal history, all right? Whatever are other medical problems that you have or medical challenges. But in general, if you are asymptomatic, you have no symptoms, and remember, a woman's symptoms of heart disease can be different from a man. They can be subtle. They can be the fatigue, the tiredness, the back pain, the nausea. So you are asymptomatic, then it's reasonable to get a coronary artery calcium score. Um, this is um, this is not a diagnostic tool. This is an assessment tool for your 10-year risk of heart disease. It doesn't tell you what other tests you have to take. It gives you an assessment of where you are. If you have symptoms, this is not the test to have. You need to move on to diagnostics. This is not a diagnostic test. So this is for women who feel fine, they're normal, they're trying to get an assessment of where they are, blah, blah, blah. No symptoms, including women who've had pregnancy complications. As far as they know, they have no symptoms of heart disease. This is the coronary artery calcium score starts to give us a baseline of what your 10-year risk assessment is. Other things that
Well,
you
wait, go back to the CAC score. Can you talk about the scoring and what it's actually looking at?
yeah, so for CAC is coronary artery calcium score.
Hmm.
And so what we're looking at are calcified plaques in the arteries, in the large arteries that are feeding the heart. And so our normal score is a 0. And generally, we like to see zeros. So this is one test that you do want to fail. A 0 is the normal score. Again, this is not the test for a woman who has symptoms that might direct you to a cardiovascular workup. These are assessments,
Right.
right? And so then if we look at labs, things we want to look at, my favorite, and it's underdone, is the vitamin D level. Vitamin D deficiency significantly contributes to heart disease. And even if your vitamin D levels have been normal all of your life, and maybe they still are somewhat unchanged, as you go through perimenopause and reach menopause, the quality of that vitamin D may be different. And so, even though the value is the same, the efficacy is less because it's not as functional. So, the same value, less function. So, you have to be careful with that. So, vitamin D levels. Anemia, always want to check for anemia and ferritin.
Hmm.
These are things that are hidden, and we can make certain that we take a look at them. Things that are mimickers of heart disease, like thyroid disease, things that have an opportunity to change during perimenopause and menopause, like your LP little a does have an opportunity to change. That is lipoprotein A. It's a type of bad cholesterol that's generally inherited. We see it a lot in the African American population and Southeast Asians, but it is in the white population as well. And certainly, if you've had any early cardiac events, you should always be screened to see if you have LP little a.
So this is really interesting, the LP little a, because I am a huge proponent of helping my clients ask for this test.
Mhm.
And as you know, the new guidelines just dropped this year that are saying everyone needs to get an LP little a at least once in their lifetime. And a lot of doctors prior to the guidelines dropping would tell my clients, you don't need that. That's just absurd. It's not, it makes no sense for you to get this test. Well, why not? Why not get it? And then also for a woman who's going through the menopause transition, I have learned that the LP little a can change. And so possibly a second look at that test is needed.
Mhm. So when we talk about, let me start at your first question. So here's a little dirty secret in medicine. Doctors don't like to test for things for which we have no therapy. So we'll draw LDLs because we've got all kinds of therapies for them. There's no therapy for LP little a. So all doctors know about it, but we don't check for it because the thought has been it's an unnecessary alarm and we can't do anything about it. We now know that that is incorrect. There are no medical therapies for it, but some are in research and on the horizon. I mean, to be fully disclosed, I'm on the steering committee of Novartis's pelacarsen, which we hope to have out in the next year. One of the first treatments for LP little a. But the fact of the matter is, since the beginning of time, there's no therapy. So do doctors know about LP little a? Yes. Do we learn about it in medical school? Yes. Do we check for it? No. Why? Because we check for it, we can't do anything for our patients. However, we know that that's wrong now. We now know that we can implement intensive behavioral changes, intensive medication regimens. So, getting that blood pressure down, getting that LDL down, less than 55, getting that patient moving and exercising, referring them to a nutritionist. So, we do know that now, we should have been checking it because even though we don't have a pill or an injection, quote unquote, a therapy, we actually could have been intervening with lifestyle changes and making certain that they know how important that is. So that's one. Your second question. LP little a is genetic. It has 10% of it that actually does change and is impacted by estrogen. So you can expect for women in perimenopause that the LP little a will increase, and studies have shown that. So this whole thing about LP little a, check it once, like one and done, once again,
Mhm.
it's male medicine. That's not relevant to females if you've had your LP little a checked when you were younger and now you're in perimenopause, late perimenopause or menopause, and you are thinking, I don't need to check it again because I had it checked when I was in my 20s. No, you do need to check it again because there's 10% of it that's variable and that's impacted by the estrogen decline. Now, if you're checking it for the very first time in perimenopause, certainly in late perimenopause, you probably do only need to check it once because you're checking it
Yeah.
at your critical juncture. But if you've had one earlier and now you're in a completely different life stage, by life stage, I mean perimenopause and menopause,
Mhm.
after pause, then yes, you've got to check that again because it does change. So, that information is not widely known. I discuss it many, many times. That is all predicated on male physiology, one and done. That's not the answer to a woman's physiology.
While we're here on the topic of LP little a and getting your LDL down under 55, I'd love to bring up the topic of statins because statins are something that have been scrutinized and they are taboo on social media. I'm on a statin. I'm on a statin plus Zetia, and I have been for many years. And I have a family genetic history of heart disease, So this is something I'm not messing around with my assessment of heart disease. And I would like to know from you what your thoughts are on statins. What do you tell your patients, and how can you respond to the negative comments about statins and women's health that we are inundated with online?
Yeah. Good for you. For whatever reason, I don't see the negative comments on statins. I'm aware of them as a physician, but I don't necessarily see them all on social media. Um, Here is something that I discuss all the time. Women are underprescribed statins in comparison to men. We're not even offered therapy. When we are offered therapy, we are more likely to not take it because of just what you said. You've been scared for, I don't even know what people are afraid of. The fact of the matter is, statins are one of the only medications available that have been shown to cause regression of atherosclerosis in your arteries, meaning you can turn back time. That's a statin. The only other one, you know what it is? It's estrogen. So,
Mm.
um, if women out there want to deprive yourselves of both, I'm just telling you from a cardiology perspective, we only have two things that actually can cause regression of the plaques. So when you are going in for your kind of wellness exam, I want to see a cardiologist. I want to get everything that I want. I want to order every single test that I need for cardiology. You need to also ask yourself, am I doing everything that I need to do to take care of myself? I'm here for all of the tests, but I'm also refusing the therapies, but I want the test. So here's my understanding of why women refuse the statins, because they've heard that it causes muscle pain and muscle soreness. And that is true. It is a side effect of the medication. It is an uncommon side effect of the medication. Every medication has side effects. It is a more common side effect in women than men, and yet still remains uncommon. It is not a reason to avoid statins. Women should take statin, take your cholesterol lowering seriously. Certainly, if you have LP little a, this is what I'm talking about. Statins are not a direct therapy for it, but they can bring down all of these other markers when we talk about that aggressive intervention to reduce everything you possibly can that can increase your risk of heart disease. So I am definitely a proponent of statins. I'm puzzled as to why women don't take them. I understand why we're not prescribed them, because women are just considered reproductive vessels. So we don't need a statin. But I am puzzled by the few women who do get prescribed them and their doctors are taking it seriously and not looking at them as just reproductive and sexual vessels while you refuse it. So that's my perspective on it. I think you should take statins because it's going to help your heart and help your arteries and decrease your risk of heart disease. And that's my focus, heart disease in women. So, yeah.
Well said. Well said. I want to talk about another screening tool before we end our podcast, the EKG. I have not had this yet. I've had the CAC, but I've heard you talk about the importance of an EKG for women who are also asymptomatic. And I would love for you to share with us why it's important, how we ask for this test, and all the nuances about it.
Yeah, so the EKG, and for if people are listening in England and with the ECG, it's the same thing, electrocardiogram. We call it the EKG here in the US, but um, this is this is a tracing. I don't know if anybody knows. We put leads on your chest, and this is a tracing that we get, and we can get an idea of the health of your heart. Quick, painless. Have it in the office, outpatient. It's part of the physical exam of men. It's not a part of a physical exam for women. Um, we do not get EKGs as part of our physical exam. We get mammograms and we get pap smears, and that's very important um, to make certain that we are not developing breast cancer, that we're catching things early, we're not developing cervical cancer. Very, very important. But women have more organs besides the breast and the cervix. And the fact of the matter is, it's the heart that's the number one killer of women. Breast cancer is actually number seven. That's
Mhm.
probably a shock to many people.
Yeah.
It doesn't even break in the top five.
Mm-mm.
So, the breast have had a much better PR firm than the heart. And good for
Very
them.
true.
And a great PR firm. Because the fact of the matter is, heart disease is the number one killer of women, and women don't get EKGs. Men do. Now, it's the number one killer of men too, but they get EKGs. We don't. We get mammograms and pap smears. So I always try to encourage women to get an EKG when you're feeling well, part of your well exam, so that you have one on your record for when you were normal and when everything was fine. So if something happens later, we have a record to compare with.
Mm.
The interval of time when changes have occurred. We can see when you last had a normal one. And that means you need to have them periodically. You don't necessarily have to have it every single year, but you might have it every 3 years. It needs to probably be one on your record. So we can kind of see what's happening, just like we follow your mammograms, right? That's exactly why we do
Mhm.
that. We follow them for changes. We compare them to
Yeah.
previous years. Women don't have that. Men have it. Um, and here's the thing, when we talk about the first heart attack of a woman more often being fatal than a man, and women dying from heart attacks at twice the rate of men, that our symptoms are dismissed, not easily recognized by either ourselves or the health system, an EKG at the hospital would be helpful if you had an EKG. So if you are there, ask for an EKG. That is a signal to the system that you're thinking about heart disease, and now is giving the system some objective data to look at. Secondly, if you have listened to this podcast and have gotten just a baseline EKG, if something happens to you later and you're coming into that hospital with these symptoms, and the hospital gets an EKG, they can quickly compare it to your previous one and know if changes have happened and during what interval. That's what happens with men, right? They have information already on their record. Women don't. I call
Right.
it's like a golf game. We have to hit the ball from where it lies. We don't have that information. We just got to go with what we have today. We have nothing previous from her. We've got, a slew of mammograms and pap smears. We don't really have what the number one killer is going to be. Men do. So they get a much more thorough and informed assessment than the woman will have because they've got information already in their records.
I am adding that to my list this year to get an EKG. So thank you for that.
You're
What
welcome.
do you want women to leave this conversation knowing that they didn't know before about their heart health?
Yes, I want all women to just know that I am here to support you. Let me just say that. I am here to support you. And I want you to also recognize that at this juncture in time, all of you have listened to this podcast, you should just understand that you actually may be armed with more information about your heart and heart health than physicians have right now. The medical system moves slowly, and our foundation has not supported this. So be patient with your physicians. I'm not saying stick with one who's not serving your needs, but I'm saying don't be frustrated. Understand that at this juncture, the public may be getting more information than physicians have
Mm.
inside the system. And if you need to change doctors and get a second opinion, please do it. Your heart health is very important, and do it in an amicable way. It doesn't have to be a
Mhm.
bad breakup. It's just kind of
Right.
this weird place where we are in medicine right now. And the doctors have no training, like myself. I had zero training on this. Doctors have no training and no information. It's not, strongly in the guidelines. Research hasn't been done because women are not generally a part of research. So you basically are in this gap. So you probably are going to have to seek out physicians who actually are interested in working on it. And it may not be as easy to find. So don't be frustrated with your doctor. Your doctor's working to the absolute top of their medical license, of their training.
Yeah.
None of this came within their training. So you may have more information than they have.
Mhm. Absolutely. Dr.
Right.
Morgan, where can people find you? And also, I would love for you to give us a snippet of Hello Heart, which you are a big part of. And
Yes.
I don't think the women who are listening to my podcast probably don't know about Hello Heart.
Okay, I will. Listen, you can find me Instagram, Dr. Jayne Morgan, DrJayne. I have a Y in my first name, Morgan,
Mhm.
Morgan. I'm on LinkedIn as well, Jayne Morgan, MD. But you can find me on Threads and TikTok and YouTube. And I really talk about heart health and women, almost all the time. Sometimes I throw in something about my kid graduating from college.
Yep.
But for the most part, that's what I'm talking about, menopause, high blood pressure. I am the Vice President of Medical Affairs at Hello Heart. We are a digital AI forward heart health company. We focus on all populations, but I have a big focus on women within that company, and the company is very interested in women. We have a Bluetooth enabled blood pressure monitor connected to an app that gives you real information, insights on your behavior, driving behavioral changes that help you control the number one driver of heart disease, which is what? High blood pressure, which is what women suffer from, pregnancy complications and perimenopause. So we are bending the arc on heart disease, addressing blood pressure directly, but integrating it into the busy lives of women so that they can do it from home because women don't have a single second to spare. Aging parents, children, careers, husbands, there's just no time to spare. And so we're bringing the opportunity to take care of yourself at home and then for you to inform your physician of what's happening.
It's such a great idea, such an amazing at-home tool to use for people. And also, I heard you once say it can be connected to other family members. So it's if you're at home, you can have a family member also connected to the app to see if things are changing.
Right. You can have another family member, but they need their own device such that because all of your
Mhm.
information is there, right? So we create trend lines. Everything is nuanced and specific to you. So your family member would need their own device as well, such that
Mhm.
your information isn't mixed in with yours.
Yeah, but it's so important because a lot of us in midlife are taking care of our elderly
That's right.
parents. Yep.
That's right. And so
Mhm.
you can, especially if you're taking care of your elderly parents, get access to all of their information so you can
Mhm.
help to
Yeah.
manage them.
Well,
Yeah.
Dr. Morgan, thank you so much for joining me on
Oh, I loved it.
AfterPause and just such a wonderful and informative conversation. I know women are going to walk away with many golden nuggets and having new conversations with their physicians. So thank you again.
Thank you. It's an honor to have been your first guest.
Yes. And for everyone who tuned in, thank you for joining AfterPause with Jill Foose. We'll see you next time. Thank you for spending this time with me today. If something in this episode made you think, good, now do something with it. That's what AfterPause is built for. If you are enjoying the podcast, please subscribe, leave a review, and share it with a woman in your life who is ready to stop piecing it together and start moving forward. And if you've seen multiple doctors, spent thousands of dollars, and are still walking away without a real plan and feeling confused and frustrated, I hear you. And I built something specifically for you. You have told me you want answers and direction on your menopause journey without a huge commitment. No 8-week program, no online course, just one focused hour with someone who knows the menopause space inside and out, has spent years building a national network of vetted clinicians, and will help give you a clear, direct path forward. No fluff, no filler, just exactly what to do next, finally. And that's my Menopause Care Consult. One time, 1 hour, and women leave with a real plan for the first time. You'll find the link in the show notes. A quick and important note before you go. By listening to this podcast, you agree not to use anything you hear as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Always consult your own physician for any medical issues you may be having. This applies to everything I share and to every guest who joins me on this show. That said, stay curious, stay strong, and keep showing up for yourself. This is your time. I'll see you next week.